So we'll come to the next presentation. This is by Thomas Haberman, the doubter. I didn't know how I was going to do this. So the same disclosures, they didn't change since the last talk. The same off-label disclosures, they haven't changed either. And my roles haven't changed either. But these are the 5 statements that I'd like to look at. And as you listen to the second part of this, this is really a phenomenal lesson, and what I believe is a lesson in what we really learned about things that we didn't know when we started on this whole journey with the, back in 1992 with the ECOG and CALGB study, and then what others went on to look at. So why is this important? I'm going to show you a different data set. This comes out of the National Cancer Database, almost 600,000 patients. And I think the neat thing that came out of this, number one, is that things were improving in lymphoma patients, all except for hairy cell, which we reported back in '93, lived as long as the normal population, and then unfortunately T-cell lymphoma. In this data set, and this is more of a prevalence number, so the incidence number is about 25%, the prevalence number is 32.5%, and so that's why it's important. So the second point is that there are 3 randomized clinical trials which incorporated different targeted agents to improve overall survival in DLBCL as a maintenance approach. This is the first trial. This is the E4494 study. Patients were randomized up front to R-CHOP versus CHOP, and then second randomization added on with our participation with the Cancer and Leukemia Group B. And if you were in a PR or CR, then you went to rituximab, and at the time, believe it or not, we didn't know the half-life of rituximab. And so we were giving it every 6 months for 4 doses, and we now know the half-life's every 2 to 3 months. But in this study, maintenance rituximab significantly prolonged the failure-free survival after CHOP, but this is after R-CHOP in this curve. There was absolutely no difference after R-CHOP. There was no difference in the overall survival. The second trial was the enoxaparin maintenance trial. And this particular trial was the Prelude study. This was a this was a randomization. It was blinded. Patients got placebo. You had stage 2 disease, bulky, and 3s and 4s. And also different here was this: you had to have an IPI of 3 to 5 to be eligible. There was a 2-to-1 assignment in this study, and patients were treated up to 3 years. You had to be in a complete remission or an unconfirmed CR to get onto this study. And you can see this is the disease-free survival. There's no difference. And this is the overall survival by treatment arm with intent to treat for this high-risk publication. There's no statistical significant difference. The third trial was just presented at ASCO, and Tom Witzig provided the slides for this. This was the Pillar 2 trial, a randomized double-blind, again placebo-controlled, again phase 3 study, and again poor risk, who achieved a CR with rituximab combined chemotherapy. In this study, so in the first study, all CT, the next study, some CT, some PET, this study all PET. There were trends that favored overall survival, the LSS and disease-free survival in younger male, Asian, and IPI 4 to 5 patients, but these were only trends. There were no safety signals. I think the major contribution of this trial is going to be to define the EFS and OS when a trial starts with high-risk patients with a PET CR who become PET CR negative. Then in this study, the 2-year disease-free survival was 77%, and the overall survival was 88%. This is the overall survival curve. Again, no statistical significant difference. This is the lymphoma-specific survival. There was a trend, perhaps, but only a trend. So what in the world happened? Why was this not such a good idea? What didn't we really understand about this disease? And I want to take you through a couple of things and the reasons that I think, and with data to back that up, to suggest why we maybe even should have figured this out earlier. But so the concepts of EFS and PFS at certain time periods were not introduced at that point in time. So Matt Maurer, in our SPORE grant with the University of Iowa, reported on the concept of event-free survival at 24 months as a robust endpoint for disease-related outcome in DLBCL in patients treated with immunochemotherapy. We looked at 767 patients in the MER, and then we looked at 820 patients in GILA and a Lyon database. So the red line is the normal population, and the black line are the DLBCL patients in the MER, and we start here at time 0. So they then ask the question, what happens if we start here? What happens if we start at 2 years? What do things look like? They superimpose. So the next thing we wanted to understand is the influence of French red and white wine, because we knew Dr. Coleman, if I stood up here at a meeting, might ask that question. And this was the data from France, from the French data sets, and it absolutely recapitulated the data. And so when you look at these curves, you see that the action has got to be in those first 2 years, and as a matter of fact, the action is even in that first 12 months. If you look between 12 and 24 months, there's about a 7% change in those curves. We next gathered data. This was under the leadership of Dan Sargent, who unfortunately passed away last fall, looking at 14 studies incorporating immunochemotherapy. So there were 5,853 immunochemotherapy treated patients, out of the 7,975, because these were randomized studies, and we looked at the PFS 24, and so you had to be alive and progression-free at 24 months. So the other one, you had to be, the EFS, you need to be alive, in remission, and not retreated. And when you look at the PFS data, so the reason we want to look at that is because now the clinical trials, if you look at population data sets like our MER, there's no time period where everybody's uniformly getting all the scans and evaluated. So the reason this data is becoming so valuable is that these patients were all followed at a very given time frame and followed up with scans and specific scans at very specific time frames. And secondly, this is a huge international data set, and I think a real tribute to our field in lymphoma, how everybody's come together and is willing to put data together and then try to bring further advances forward. So at 3 years it was 93 versus 94%, 5 years 87.6 versus 89.5, and at 7 years 80 versus 83.7%. We'll probably never get very good data after this. There's a tremendous decrement in what we all submit. And there was a marginally lower but clinically indistinguishable from the age, sex, and country-matched populations. You got to go country-matched here too, which I won't go into. And you can see on the far right curve the normal population in red, populations in red, and then in black the those that didn't relapse. Look what happens here. If you progressed within the first 24 months, you now have a survival rate of 20% versus up here we're in the 80% range. So, and then look, where's all the action here? All of the action, at least half of the action is in the first 6 months. It takes 18 to 24 weeks, depending upon whether you give 6 or 8 cycles. And then there's a significant decrement that comes down to that 2 years, but you could see again, we're looking at a small percentage, the year 1 to 2. So I think we have to look at the action up front. So the current understanding in the biology of the disease doesn't support this either. Again, we didn't know much back in the early 90s. I'm not convinced we know as much as we think we did today, and today as we might hope. And I think Gail Robos this morning put a little reality of the day into our thinking about some of this. But what we did is, the first paper was in PNAS. The whole exome sequencing was done out at the Broad and the Farber, and we provided all of the cases. And then this particular paper is the clinical data to go with it and outcomes, and we attempted to apply this whole EFS principle. And so, again, as we talked about this morning, and now, John, I do have my obligatory genomics paper present here. In green, these are the EFS24 failure mutation cases. And to make a long story short, we're all trying to sort this out, and we're not very smart yet. But some of our thinking is that in our grants that we have approved now and so forth, we're trying to really understand where this is. But I think that's until we begin to understand some of this biology and then be able to target that biology, we're not going to be able to make much more sense out of some of all of this. You can see the driver mutations in orange here. They're driver mutations which are failures, and they're driver mutations that were present in those that achieved an EFS24. So this isn't very simple, but I think this green area is where, at least we're thinking, where the action might be. Dr. Sandeep Dave and their group had this paper at ASH, and he did give me permission to present all the plots, but I didn't have it from the journal, so I won't show that. But they reported on, this is the 1001 project of 1,001 different DLBCL patients. These are paraffin. The previous work I showed you all came out of fresh frozen because the technology, that's all it would allow at the time. And they reported on 197 recurrently mutated genes in 15 functionally related subnetworks. And I think we're just beginning to understand these subnetworks. Cell of origin was independent of MYC and BCL2 co-expressions. Mutations in EZH2 and CD70 were associated with a favorable prognosis in GCB, and the TP53 were prognostic in MLL2 and high BCL2 expression patients. So where do I think it's going to go? I want to just touch on lenalidomide and everolimus phase 2 trials. And the NCI steering committee in lymphoma, there are members present in the room on this committee. Tom Witzig has headed it at one point in time. And the plan was to move to an XR-CHOP, so there's no maintenance in there. And there's no consolidation with transplant or other such things. John's been very involved in the bortezomib story, which I won't go through. The ibrutinib story is in phase 3, but I just want to talk a minute about the lenalidomide and the everolimus. And this is we did both the phase 1 and phase 2 work, and this is the paper from the phase 2 study. And so this is just R-CHOP patients treated here. And so if you got R-CHOP, and this is the and we're looking at some retrospective data out of our Mayo Clinic lymphoma database. So this is different than the MER, but the 24-month progression-free survival was 28% versus 64% for non-GCB versus GCB, and this was immunohistochemistry, and the overall survival was different at 46% versus 78%, and you can see those p-values. In our phase 1 and phase 2 studies, this is just the phase 2 data, if you got R2-CHOP, these numbers then for the progression-free survival were 60% and 59%, and for the overall survival, 83 versus 75%. This was the progression-free survival. Again, this was out of the database. This was the trial. The overall survival curve looked exactly the same. So it potentially, and now there's randomized, we're doing the randomized studies to look at it, randomized phase 2 in the cooperative group structure. There's a large international study also going on. but we potentially are improving things by 30 to 40% here. In a phase 2 everolimus study, we're absolutely intrigued with this, and it's single institution, and I want to be very careful how I present phase 2 data and so forth. But we put 24 patients on study, and so far in large cell lymphoma, 24 out of 24 have not relapsed as large cell lymphoma, and they're out over 24 months. This was the paper. We've just submitted another paper, and so the one relapse was a follicular relapse, and again we did functional studies on all these patients. So we think they're taking the approach up front and looking at newer regimens will be more important. So again, these were my 5 points to cover in this topic. And again, I want to thank everyone for your attention.